All right. Well, good morning, everybody. We're going to go ahead and get started with the meeting of the Episode Quality Improvement Program. I have a lot to go through today, but it shouldn't take too long. When I say a lot, I mean a lot of good content, but it shouldn't take the full time of the meeting. Very, very excited, and I think we'll go through some numbers in a little bit. We did have an increase in the number of people who applied, and we had doctors in all four of the new specialties apply. Or care partners, I guess, as Will likes to call them. It's just good news that the program's continuing to grow and expand, and we're getting more and more alignment between the physician community and the caregiver community and the hospital system. So this is great news. I think, again, just as a pre-reminder, it's really important if you're interested in adding codes that you start talking to Will, myself, and Jessica, so we can set up meetings and begin to have discussions. If it's Prometheus codes or from the Prometheus list, it's a little easier. But if it's something new, we really need to have a discussion and start doing work now so we can begin the process and talk to CMMI in the spring to try to get it online for January of 24. So we'll go ahead and get started. And you want to go ahead and advance. Here's the agenda for today. You want to go ahead one more, Jessica? So obviously, and I'm going to do the MHCC grant, and then I'm going to turn it over to Jessica to go through enrollment next steps, care partner arrangement walkthrough, data availability, and episode development. So let's go ahead and go to the MHCC grant. So last year, the Maryland Healthcare Commission gave MedChi's CTO a grant to do practice transformation. And last year, we really targeted the Maryland Primary Care Program. Specifically, we were looking, we did a few practices that were not in EQIP, but might be eligible. But really, the bulk of the folks in the initial round of the grant were people who were primary care doctors who had not been in Maryland primary care, and we wanted to really help them out with it. And essentially, what we did was we did practice evaluations, and then there are 6 CMMI modules, CMS modules on value-based care, and there was a small subsidy for the practice for participating in the education program. So we're doing the work now on that part of the grant. And it's very exciting. We're getting these docs who really were not ready for this to do more, and there's funds to do it. So this is a free program where they can actually benefit from it. And the Maryland Healthcare Commission has now expanded it. And I was hoping to have Melanie talk about this second round of the grant that we've opened up. So Melanie, if you want to come on and unmute yourself, maybe you can tell everybody about what we're doing now and what's open under phase 2 of the grant, or the second round of the grant.
Great, thank you. Can you guys hear me?
Yep.
Good morning, everyone. And Jean, thank you for letting me speak for a few minutes this morning. So first, I want to commend MedChi on the tremendous work they've done under the Practice Transformation Grant, and just provide a really brief update. So MHCC has a rich tradition in practice transformation that goes back to 2010 and the groundbreaking work we did on the Maryland multi-payer PCMH program. So we're excited to be able to offer round 2 to the practices due to the success of round 1. So as Jean mentioned, round 1 practices are finishing up their custom workflows, they're completing quarterly assessments, and the next phase is training that includes the collaborative learning component. The training is designed to support sustainable implementation of the workflows and other practice transformation activities. Practices have been raving about the quality of the program and the MedChi transformation team. So we're currently accepting applications for round 2 practices interested in learning the key elements to succeed in value-based models like EQIP. So if anyone knows of practices, so please send them to Jean or I, and we are happy to answer any questions. So thank you for allowing us this time this morning, Jean.
Yeah, and I got to say the Healthcare Commission is great. Melanie does a great job, as you all know. But the Healthcare Commission has been great. They really pay attention the entire process through and make sure everything is going well. There are no restrictions. It doesn't matter if you're a hospital practice or you're a private practice. Really, it's for anybody who is not in a value-based. The sweet spot is anybody who's not in a value-based care program who needs to learn more about it. So I'm going to send out the applications and the one pager to the list today, so please share it. I think for those of you, who are parts of bigger systems, you probably have physicians or care partners who maybe are in smaller private practices. This might be perfect for them. For some of you who maybe have departments at your hospital who have been hesitant to participate in EQIP, maybe it's something that they could consider applying for. Melanie and I are happy to do calls with anybody who might be interested in this opportunity. The goal is really to learn about value-based care and see what you need to do to transform. And I think one of the things that we have to do is keep talking to physicians about it, because I know that it's been we really haven't switched a lot of physician payment model away from fee for service, but it is really coming. And I know we've been saying that for 10 or 15 years, but it really is coming. So this is a great way to learn about it and think about it and think about it in new ways. So I really appreciate the Maryland Healthcare Commission and all their work on this, and we're happy to help anyone. So having said that and started with that, I'm going to turn it over to Jessica to dive into EQIP.
Thanks, Jean. Okay, so I'm going to give a little bit of the administrative update and sort of talk enrollment next steps. So as a reminder, this is sort of where we are on the timeline for enrollment. Enrollment did close Friday, September 2nd. I want to thank everyone on this call and people who did some internal recruitment. We know the window is pretty short and we're really happy with the turnout, so we appreciate that. Sort of in this September, October phase is where we do CMS vetting. We do some tweaks and finalization about audits. I'll speak more about that. And then we lead into the actual contracting, signing the care partner agreements for everything to be finalized and signed on the dotted line come December 31st. So here's where we are from enrollment. We're really happy, as I mentioned. We will be submitting 8,300 actually plus different unique care partners to CMS for vetting. This is up about 1,000 from last year, so really happy with that growth. As you guys know, we had a drop down of like 43 different specialties. There was representation from all of them that were submitted. And then we have 66 EQIP entities. Again, that's up, I think, about 10, if not more, entities from PY1. And we're also very happy that all of the entities from PY1 are agreeing to participate again in PY2. And then of the 45 available EQIP episodes, we have someone participating in every single one of them. So again, that's sort of great news for us. And then obviously these numbers will fluctuate and will change because the final number or final participation status won't be determined until the actual start of the performance year. So as mentioned, the end of this year, HSCRC and CRISP, really what we're going to be doing is we're going to help participants sort of finalize this vetting status and eligibility. We're going to adjust any care partner lists that may be needed based off of audits. And then we will assist with completing the contracting phase with UMMC. Okay, so what's going to happen is really this is communication that's going to go out to our different EQIP entities, and they really kind of fall into three main categories. The first is we did notice that there's about 200 plus care partners that were actually duplicated across different entities. Care partners or an NPI can only exist on one entity list. So we will be reaching out shortly to that care partner and the lead care partners and the admin proxies of the duplicated care partners in order to determine where they should appropriately fall. As with last year, our policy is if we don't hear anything or a care partner does not attest to a preference and no one claims them, that care partner will be assigned to the smallest volume entity. So hopefully you guys just let us know and we can clear that up, but that is the default if we do not hear. The next step is sort of our auditing phase as far as eligibility. We've mentioned this before, but EQIP entities must have 75% of their care partners touch at least one claim in that baseline episode period. So we're running those numbers and we'll reach out to entities who did not reach that threshold and ask them to adjust their lists as needed. If you don't hear from us, that's good news. Your threshold was. And then the next step is we expect probably late October to get the first round of CMS vetting results. And that's really the PICOS audit, which we find is the largest drop off when it comes to CMS. So we expect to get that result back and we will post that eligibility status of those who did not pass in the EQIP entity portal. So you'll be able, again, to see, and if there is any eligibility changes because of that drop off, we'll reach out to you guys and work with you guys one-on-one. And then finally, the second part of CMS vetting really comes back late 2022. So that will sort of be done in parallel to contracting. And that's a law enforcement portion, but we do expect those numbers to be pretty small and have minimal impact. But that's sort of the next sort of steps with that. Okay, so let's talk about the care partner arrangement. So as you guys know, our arrangement with the state and CMS is that incentive payments cannot be distributed to an individual and an entity other than a care partner with whom the hospital has a fully executed written care partner agreement. So what that means is that these are required. And we have a standard care partner arrangement for all care partners. The care partner agreement from last year is up on the website. There's going to be very small tweaks, but if those people are interested in what it looks like, you can reference the one from last year. And what's going to happen is, as we mentioned, we will have sort of that initial drop off from CMS. So those care partners that have not been removed or deemed ineligible will have an automated, pre-populated care partner created for them that they will be able to digitally sign. And again, that deadline for them to return that is December 31st. Those that do not return it by December 31st will be removed from the program and not be able to participate. And again, some of that timeline could tweak depending on our CMS vetting, but in theory, that's sort of our goal for that. So the requirement for PY2 is slightly different than PY1. So all new care partners who were not participating in PY1, of course, need to sign a care partner arrangement because they do not have one on file. Luckily, most of the care partners for PY1 do not need to re-sign. The only reason you would need to re-sign a care partner arrangement is if you fall in one of the two scenarios. The first is if the payment remission recipient changed. And of course, that's important because you were testifying, or not testifying, you're agreeing that any incentive that you may have earned as an individual is aggregated at an entity level and is paid as a lump sum to one single payment remission recipient. So if that changes, you will need to sign a new one. Additionally, if the care partner changes entities, so if you guys split into two or you created sort of a new one and two ones merged together, you will need, all those care partners would need to re-sign an EQIP entity. Or sorry, need to re-sign a care partner arrangement. And again, we expect these to be sent out starting sort of the 1st of November, pre-filled, standard. We do not expect there to be any changes, or really no changes are allowed, but if there is any issue, you guys can reach out to us, and they actually will come from our CRP entity themselves. So just reminding people about that deadline. And I think that's it for updates. Here's a reminder from a timeline standpoint. October, November, the other big thing that will come out is the performance data will be released late October. So we had a little conversation beforehand. We'll go over that at our next EQIP meeting and review the performance data available. And that's sort of it. So if there are any questions before I turn it over to Will, please let me know.
Okay, thank you, Jessica. So I'm going to talk very briefly about the data availability. Oh, I'm sorry, we did get a question. I don't know if you want to answer this first, Jessica.
Yes. So actually what we did last year, which worked out well, is we sent all of the care partner arrangements to the admin proxies and the lead care partners and relied on them to disseminate and coordinate the signature of it. That made it easier than going to like 1,000 different emails. So it will be, all the communication really will be directed through those admin proxies and lead care partners. So we will definitely let them know, and the signature status will continue to be updated about weekly in the EQIP portal, so you guys can follow up, if there's someone that's still outstanding.
Great, thank you, Jessica. So I'm going to talk very briefly about the data availability and the target prices. At the previous SIG meeting, we had a conversation about potentially providing more data earlier, and also about when the target prices became final. So I'm reporting back to this group on sort of our work there. So next slide, please. So in terms of the data availability at the last SIG meeting, several participants requested incomplete data on their EQIP episodes so they could get that data earlier in the performance period. The idea, I think, there is to both know who their EQIP beneficiaries are and get an insight into how they are doing as early as possible. Unfortunately, the Prometheus grouper will not work with incomplete data, so we're unable to provide data earlier, even incomplete data. So in general, the episodes will require 90 days of episode runout plus 90 days of claims runout, and will be available 180 days after the episode starts. And then the data availability is either shorter or longer, depending on the length of an episode. So 180-day episode obviously is 270 days after that first episode. We run and update the data quarterly. And so the data will become available in the portal to you sort of 180 days after the episode starts, and then at the next quarterly update. Now, excuse me. Sorry, I'm losing my voice. So going through a crisis of, do I have COVID? So we recognize that participants would definitely benefit from getting data earlier. However, we just don't think that we're going to be able to do it with claims data. Also, in our sort of experience with both this and other programs, the claims data really is not terribly useful when it is incomplete. That being said, we're willing to work with providers to see if there are other sources of possible data that we could provide. Something like an ADT feed, working with medical records or other data sources. I think we are happy to engage in some conversation about how we can build a more robust and more clinically useful data system going forward. So if you have suggestions on sources or types of data that would be useful, please reach out to us at equip@crisphealth.org. So I'll pause there, see if there are any questions. Great.
So I will say this, Will, I do think it's really important that we maybe get a group to discuss this more, because it puts practitioners at a big challenge if they're not going to have any information until 3 quarters into the performance year. So we need to figure out how to solve this problem, because I am concerned that you just, if you're doing something wrong or something that's not working, you don't know about it till you're 3 quarters of the way through the year. So it's hard to fix it. So I've got to believe we can find something else that can get us some kind of information that we can use to be successful. So I'd ask, and I see we have a handful of physicians on the call today, maybe a couple of them can think of something else that we could get information from so we can be successful. Anyway, that's my only comment.
Yep. So I think, Gina, getting a group of us together to think about creative data solutions, I think would be very beneficial. I think it's a sort of a simple matter of time, right? That we really won't know how your episode's performed until 180 days after the end of that episode. But there does have to be sources of information that could be more clinically useful, right? An ADT feed for any time a EQIP beneficiary goes to a hospital or a acute care setting, for instance, I think could be helpful in knowing whether or not you're on track controlling their probability of readmission, for instance. So let's definitely get some folks together. If you're interested in that, either reach out to us, I guess, or Jean.
And I'll just add, CRISP is happy to work with any EQIP entity that would like to use encounter notification services as a way of identifying patients. So obviously it requires a little bit of coordination between us and the practice to ensure what information is being sent over, but happy to pilot it, happy to work with people. So if that's of interest as well, reach out to us.
Wonderful. So if you could go to the next slide. So the second question that we got last month was a question on the target prices. Currently in the EQIP portal, participants see a preliminary target price, and several participants asked when that will be finalized. So the answer is the target price will be final after the end of the year, but I want to explain the reason for that. So the preliminary target price is equal to the baseline costs in today's dollars, and literally today's dollars. So that means that we take the baseline costs that occurred in 2019 and we update them with all the inflation that has occurred between 2019 and September 16th, 2022. However, there are updates to Medicare payments that occur during the course of the performance year. So for instance, there's a big IPPS update that takes effect on October 1st. So we don't call the target price that you see final. It reflects what the target price is for episodes that are triggering today and costs that are incurred today. But then on October 1st, it'll update to incorporate the additional inflation that occurred as a result of the IPPS update. And there are a variety of updates that happen throughout the course of the year. Most of them are going to be input, are going to be in the target price by July. So there's sort of two big sources. There's the PFS update, which is on a calendar year basis, and then there's the HSCRC updates for hospital costs that go in July. But there are a variety of updates that can occur after July. And so we don't call the target price final until after the end of the year, because that includes all of the inflation that occurred during the year. But the preliminary target price that you see today should be an accurate target for your episodes that are triggering today and are incurring today. The only reason why it's called preliminary is that it doesn't include sort of future inflation, which hasn't yet occurred. And most of the updates are going to be in place by July and almost certainly by the fourth quarter of the year. However, the federal government occasionally does very strange things at very strange times, for the sequester. And so we'll continue to call that a preliminary target price until the end of the year, when we know all of the final inflation factors have been put in place. So I'll stop there, see if there are any questions on that.
This is William Henderson. Just one more point to add to this: because we're adding inflation, the target price should almost invariably go up, because typically there aren't negative inflation adjustments. So that's also something else you can think about.
Thank you, William.
Now, you may have other mixed things going on, but in general, for the same episodes, it's going to go up.
Okay, seeing no questions, Jessica, if you could go on to the next section. So we do want to start talking about performance year 3 episodes. Our development cycle basically will take a year from when we start working on an episode to when we're able to put those episodes into EQIP. So this is for episodes that will start on January 1st of 2024. We want to start now so that we have plenty of time to work with stakeholders and also to do our own development process and get those episodes available for enrollment starting in the summer of 23. Again, these are 4 episodes starting on January 1st of 24. So we're asking right now that if folks are interested in creating new EQIP episodes, to please reach out to us and to start that process now. So that we can do some work planning and project management and ensure that we have enough resources to devote to each of the new episodes we're going to be developing. Next slide, please. So if you are interested in developing additional episodes, what we're going to ask from you is a list of triggering procedures or diagnoses that indicate the start of that episode, and a list of included and excluded costs for that episode. So a list of costs that are considered clinically relevant to the diagnosis of the episode that you're targeting, and a list of costs that you want to exclude that are not clinically related to that episode. That's really all that we need, but we do need, actual codes that will trigger the episode, right? So we need the CTP codes, ICD-10 diagnosis codes, DRGs, et cetera. We anticipate being able to add 1 to 2 episodes per year. I'm going to define that episode sort of broadly. For the ED docs, working with them, we were able to add 1 new area. We were able to add ED episodes. But then there are a bunch of actual conditions that trigger an episode within the ED. And so, if I think we'll be able to do, one area, maybe oncology, maybe dermatology, something like that. And if there are a bunch of episodes underneath that area, that will be fine. So we're going to prioritize which episodes we developed based on the number of interested physicians, which is another reason why we ask you to reach out to us early on and start working with us in this fall, so we have a good sense of which physicians are interested or other healthcare providers are interested in doing a new episode. We are committed to getting to everyone. This is just a matter of sort of triaging, limited resources. And so we're going to operate on some combination of first come, first serve, and who has the most interest in that area. But we will, over the course of years, get to everyone.
We have a question in the chat, Will, and I'll do the second one and let you answer the first one.
Okay.
So the second question is, do we anticipate CMS APM program continuing in 2023? And I'm assuming he's referring to the 5-point bonus for being in an advanced payment model. And the answer is that obviously we don't know. There is legislation before Congress, and MedChi is working very closely with the AMA and other organizations to see that passed. The strategy is to try to get it done in the lame duck session and to get it passed so we can keep the 5 points. Obviously, that is very, very important to Maryland because we have a large number of people in APMs in Maryland through EQUIP, but also we expect the Maryland Primary Care Program, knock on wood, to get its status back too. So losing that 5-point bonus is huge for us. So what I would suggest, Kemal, is maybe if you are part of a national organization to encourage them to participate in that fight in Washington to extend it. But right now it is not happened. We have to pass legislation to make that happen. And Will, I'll let you answer the first part about the about adding PT.
Great. So the question is, can we add PT, physical therapist or occupational therapist in the program? I think there's two answers to this question. The first answer is we will include literally anyone who's able to bill Medicare under their own scope of practice. So a nurse practitioner, physician assistant, et cetera. Anyone who can submit a bill to Medicare can potentially trigger an episode and therefore be included in EQIP. For people that don't bill Medicare, they can still participate in the program by helping the person who is billing Medicare for that patient to manage the episode costs. So if there's a physician that's responsible and a care coordinator or care manager, they're doing obviously very important work in helping control the episode costs, and their work will be reflected in the performance of the physician's episode that triggered the physician that triggered the episode. And so I think the answer is, and I'm really not sure for physical therapists whether they can bill Medicare in Maryland. If the answer to that is yes, then they can participate in EQIP. If the answer to that is no, they can still participate by doing care management and helping contain episode costs. They just have to make sure that the physician that is billing for that patient is also in EQIP, so that episode is triggered. Okay, so it says yes, PT can bill Medicare, then yes, they are in. Wonderful.
And I will just note that we actually do have some PT that were submitted this year, so that's a good thing. But yeah, and Will, I'll just make one comment, and you can correct me if I'm wrong, but I believe if a provider does not touch a claim in the performance year, they're put on probation for the following year and then need to touch a claim or else they'll be deemed ineligible. So they can participate, but they do have to touch a claim. They don't have to trigger a claim, but any claim that's included in the episode in order to participate year over year.
Great. Any other questions on additional episode development?
Yeah, I just want to reiterate what Will just said about the importance of thinking about this now and not waiting. These are not easy. You know, Dr. Pines, I know, was on the meeting. I saw him log in. The amount of work he did to get the ER codes approved for this year was significant. And if this is something that interests you, really, it's important to reach out to us like now so we can start working on it. Obviously, if it's on the Prometheus list, it's a lot easier and we can get it added much quicker. But if we're doing something different or unique, and I think that's probably where we are for most of the codes, we're going to have to start thinking of new things, because I think the Prometheus codes that kind of make sense, I think we've put on. There might be a few others, but so far we've kind of done the ones that make a lot of sense. So we really need to start working on it now. I would just encourage, for the larger hospitals or the larger practices, it's a pretty cool opportunity to kind of work through and get something done. We have also, MedChi reached out to all the national specialties and said, you know, you've applied for different programs to PTAC. Are any of them logical or eligible for this? And we haven't heard much back. So we'd love to see, this is a cool opportunity. Where else can you get an advanced payment model set up in America this quickly? So I think we should take advantage of it and figure out how to do innovative new things. And I just really would encourage folks to talk to people who have ideas and work with us so we can get a nice package together for next year.
Great, wonderful, Gene. So in conclusion, please reach out to us if you're interested, and we will work with you to help develop those episodes. And I think that's it for me, Jessica, unless there's another slide. Just thank you.
Nope, that's it. And I did drop the Prometheus list. If there are any Prometheus episodes that people are interested in, you guys can go through that. And then Jean and I can follow up and put together a learning collaborative for some of the data concerns that were sort of brought up. So we'll reach out.
So one last thing, I understand that an email has just gone out from the board chair of CRISP that Craig Bem was named the new CEO of CRISP. So I think everybody at MedChi and probably everybody on the call wants to congratulate Craig. What a great choice. So impressive. So I just saw that. So I wanted to say congratulations officially. And for those of you who don't realize this, Jessica works for CRISP, and CRISP is incredible and does a lot of work to make EQIP run, and they do lots of good things. And I think they picked a great person to be in charge.
Definitely. Congratulations, Craig. Is he on this call, or is he?
I don't know. He does something.
I'm out. Okay.
So I just figured everybody on this call knows him. So they'll all be happy for him. They can all send him an email. Congratulations. Anyway. All right. Anything else? Any other questions for the good of the? Oh, this is like a record EQIP meeting, I think, guys. Oh, we got another question. Jessica, do you want to handle that, or Will?
Sure. So the question is, for care partner arrangements, will you be sending us the outstanding agreements to be signed? Yes. So we will only be sending those that require signature for PY2. So we won't be sending everyone. I think that was the question. Kendra, let me know if I interpreted that wrong. Yes. Okay. Okay. I think that's it, right?
Yep. Okay, well, thank you all.
Have a great weekend, and go Ravens. All right. I guess we're supposed to say go Commanders too. Anyway, or whatever they are. All right, guys.
Thanks.
Bye,
See
everybody.
you.